So in this, this is another data from a declare event. Look at the control arm, your event rate is 19.5%. So these are the newer publications. So whatever you do, quadruple therapy or quintuple therapy, event rates in control arm is somewhere between the range of 15 or 20%, and all these data are not more than 2 years at best. So there is a lot of unmet need, and we keep on evolving. So apart from the 4 foundational therapy, another pathway apart from working on the neurohormonal axis, that is the sympathetic or RAS, or working on the SGLT2, or there is other activation models, and one of them is the cyclic GMP pathway. And Victoria trial is one of the important trial which has shown that even in sicker patient, if you add this molecule, you get the benefit. The inclusion criteria was important. In this, they took less than 45%. I don't know why. Nowadays, definition is 40%. And they have to have either heart failure hospitalization therapy, heart failure hospitalization last 6 months, or there is escalation of diuretic in last 3 months, and NT-proBNP has to be high. Then they were given 2.5, 5 milligram and 10 milligram vericiguat, and were followed up. And what it showed, there was a 10% reduction in the relative risk reduction. And although the mortality benefit was not that great, but there were certain good pointers. So the worsening heart failure annualized risk reduction is 4.2% with NNT of 24. So this is the one of the addition on 4 foundational therapies. If you meet the criteria of worsening heart failure, your event rates will still go down. And mind you, these are the very sick patients, unlike all other trials for 4 foundational therapies. Like mean NT-proBNP in this trial was 2800, unlike 14 or 1500 in other foundational therapies. You can see in this chart, Paradigm was 1600, whereas in Galactic was around 1900. But look at the Victoria trial, it was 2816. So these patients were really sick patients, and still you could achieve annualized absolute risk reduction of 4.2%. So still you are getting a benefit, although the p-value was not that great, but it did make a very important impact. So what is the current scenario? If you are unable to give these medications, particularly because of the EGFR issues, because of the potassium levels, because of the very borderline blood pressure, so it comes to our rescue. And there have been a publication known as the paper data set from the Germany, that if you add this molecule, it helps you to bring ARNI on board in a good number of patients. So these sick patients, very lowest blood pressure, creatinine on the higher side, potassium on the higher side, we are unable to give RAS blockade ARNI in particular. So if you give them vericiguat along with beta blockade, most of these patients will recover in coming months. Then it will pave the way for the introduction of MRAs and RAS blockade ARNI in particular. Regarding the doses, this does not cause much of the hypotension. The reported drop in systolic blood pressure is only 2 to 3 millimeter. So in fact, there is nowadays newer studies, probably you can start with 5 milligram, but the dictum is to start with 2.5 and go on increasing to 5 milligram and 10 milligram once daily. And we can give it up to a EGFR of 15, not much effect on potassium. So I was alluding to this slide. If you start with the smaller doses of the all 4 foundational therapies, you get the best result, rather than bringing up the dose of one therapy to a maximum, then keep on adding other foundational pillars. Nowadays, we are doing smaller doses, all the 4 drugs, if there is no absolute contraindication. And if there is any absolute contraindication, probably we'll chip with these alternate pathways of cyclic GMP. So vericiguat is probably one of the fifth pillar if you are already on 4 foundational therapies. Just to remind you that when this trial was done, SGLT2 inhibitors were not on board. Only 2% patients got SGLT2 in Victoria trial. So we don't know if someone has to do a trial today, how the result will be. But if you give SGLT2, it also, like vericiguat, paves the way to introduce other molecules, particularly hyperkalemia is much less. In fact, potassium is on the lower side if you give SGLT2. So all said and done, we are always trying to add other pillars so that these unmet needs of 14%, 15% bad outcome can be ameliorated. And the iron therapy in heart failure, even without anemia, is important concept. Addition of alternative pathway activation, particularly the cyclic GMP activation, is another avenue, particularly for the worsening heart failure. Whether it will come in a stable, so-called stable heart failure without worsening, I think the time will tell, and we are waiting for publication of that data set. So unless that is published, nowadays role of vericiguat or cyclic GMP modulation will be in fashion, particularly if you can prove that my patient of heart failure is having worsening heart failure. I'm not sure whether what will the data in heart failure preserved EF. That is the different ball game. Coming back to my first slide, why the mortality is increasing after 2011 is probably because of the more prevalence of the obesity, because of the more prevalence of heart failure preserved EF, which does not have much of the treatment apart from the diuretics and SGLT2 inhibitor, is the cause of increase in mortality despite the quadruple or quintuple therapy. So I end my presentation here. Thank you for the patience hearing.